Okay, well, good morning, everybody. Folks are still kind of rolling in, but we're going to go ahead and get started. Our webinar today is a case for parity. Michelle has got some interesting things she's going to talk about with urban versus rural environments.
Thank you, Amanda. I also have with me a couple of friends. That's Carol Yarborough and Brooke McSwain. So I would like to welcome them.
Thank you. Glad to be here this morning.
Yes, thank you.
Oh, thank you. I appreciate you being on and sharing your expertise. So Brooke and Carol will be on for about 30 minutes. This webinar is a little shorter than our typical webinar. I think we're doing, our timing is somewhere around 45 minutes. So we'll try to allow time for some questions. But Brooke and Carol will be on for the first 30 minutes, and we'll make sure to ask them questions before they have to drop off at at noon. And there's me and my experience. So we're going to talk a lot about, what we want to talk about is the parity case. And what I'm seeing a lot of is people pushing back and saying there isn't a case for parity, that there actually is a case for not having parity, given some of the costs related to maintaining brick and mortar, clinics, etc. And also seeing some of the direct-to-consumer solutions that are, I think, in some ways pushing for this, as well as some others that are, quite have some pull in the industry as well. So I want to push back on that a little bit. I want to talk about it, but I'm also interested to hear what all of the attendees and also Brooke and Carol have to say about it as well, so we can round out this argument, because I think we need to start thinking about this as an industry and how we can really address this. So from an overall population perspective, we know that the population is outpacing healthcare capabilities based on the data that we had back in 2019 and 20, that you can see that's all referenced there. We know that, baby boomers are 52 million from 2018. So that's 3 years more. We've got even more folks that are in the retirement age that will be utilizing healthcare services even more. 19% of the population will be 65 or older in 2030. So the heaviness of the age group that will have chronic disease and will have more healthcare usage will be even heavier as time goes on. We've always talked about that, how baby boomers have pushed on the abilities of healthcare to keep up with the population. But I think this is a key cornerstone in why parity is also needed. We also know that over 90%, based on this bottom right-hand corner, 90% of healthcare expenditures will be spent on Americans with chronic disease. And we know that healthcare, telehealth in particular, can be very helpful in managing chronic disease. So this is a federal map of those medically underserved areas. The yellow areas are those that are medically underserved. The majority of this map is yellow. So most areas are underserved. There are, of course, some areas where we have up here in our northeastern section where we have a megalopolis and there's tons and tons of healthcare systems, and we're pretty good and saturated. And there are some over on the West Coast as well. But for the most part, we have a lot of medically underserved areas. So we have a crunch of medically underserved areas, overpopulation, and of course, not enough physicians to meet the demand. And in rural America, and I'm just going to slip back here to this slide again, you can see much of that is rural America, where we have underserved populations, and a lot of that in tribal lands that we see over on the West Coast as well. Those all are in rural areas, which have even higher challenges to access healthcare as well, including, technology issues. But for rural America, we know that telehealth, and in particular, places in rural areas where people are being transferred from rural hospitals into main city hospitals, so then their families are far away. Obviously, those are just convenience areas and don't necessarily speak to specifically parity, but it speaks to the overall flavor of what's happening. We know that telehealth can help improve the monitoring of those chronic disease management, chronic disease patients that we talked about. Fewer patients will have to be transferred. They will be able to stay in those areas, and we won't see as many hospitals closing, because that's certainly happening across the country as we see them not being able to handle higher acuity patients. They're immediately transferred, and therefore those revenues go down, and they can keep those patients in those smaller institutions. And obviously, patients don't have to travel long distances, which reduces the cost for insurance companies. When we don't have to travel, or we don't have to ask an insurance company to pay for a second opinion, for example, to travel to another city, then that reduces the overall cost of care. So telehealth in that case is reducing the cost of care. We know that that is an overall outcome as well. So from a physician perspective, you can see there's a shortfall by 2033. So we're seeing the crunch, population increasing, underserved communities, physicians, shortfall higher and higher. We're seeing fewer and fewer primary care physicians that are being graduating from schools. And this data is very fresh. This is less than a year old, this data. So we know that we need to do something to expand the amount of clinicians that we have, whether that's utilizing advanced practice professionals more. And we also need to use the technology that's available to us. I've often heard people talk about, banks, and we thought for sure we would never be at a bank where we couldn't speak to the person, we couldn't go to the teller and have our banking completed with the teller. That's not actually the case now. I think if I have to go inside the bank, that's more of a hassle than if I can just go into the ATM and do everything that I need, or even do it online at my desk. So the same is true for healthcare, and we're seeing that coming more and more with patients as well. And even more on the shift from rural to urban area. As the population shifts, we see that people in the rural areas are left in those areas without clinicians there. So those rural counties that do gain some population are reclassified as urban, and then they're less likely to get payment for telehealth because they're not, or for other services as well, because they're not now defined as rural. So we see the population shifting happening. We see the compression of the physicians, and then as we can see down at the bottom, an urbanization as the urbanization increases, older patients are older, sicker, and poorer in rural America. So we're making the situation worse as population continues to shift. And we're also seeing those clinicians not practicing in those underserved areas that we talked about. Again, same thing, fewer providers, more rural areas. And you can see that over down at the bottom, over 54% of rural voters say that they would access to a medical specialist is a problem in their community, where in an urban area that's only a third. So more than half in a rural area say this is a problem. When we look at OBGYN services, this is even worse. So only 6% of OBGYNs work in a rural area. So we see in rural areas higher infant mortality, higher maternal mortality. We see a lot of chronic disease increasing. So the cost of care, the total cost of care without telehealth, without chronic disease management via telehealth, is so much higher than if we utilize telehealth, where we can head off some of these issues that we're seeing that are cropping up in these rural areas in particular, but that's true in urban areas as well, where they're not able to access the healthcare because it is too far away. If that's 3 or 4 or 5 miles away, then that's just as far as 20 if they're not in a rural area. So again, telehealth reaching those patients. And then finally, before I ask Brooke and Carol to jump in, we also know that in rural areas, we have to address to expand the medical workforce, and we have to address the broadband issues that we're seeing. So we know that this is a bipartisan issue. Thank goodness that we can get broadband to be expanded throughout the country, because this is a key issue for not only healthcare, but education and other services that people need to have access to. So expanding the medical workforce through local, state, and national efforts is really, really important, but we're not graduating enough. So we need to do more and how we expand our scope of practice laws, also by being within the concerns that we have in the industry, and making sure that we manage the quality around those services, because there are some concerns about overuse and quality of care, and some fraud associated with that. So lots going on there. So I'll pause for a second and ask Carol and Brooke to weigh in there. Carol, I'll ask you to weigh in. I see the link that you shared in the chat.
Yeah. So I don't know if anyone saw the IPPS draft come out for 2022, but Medicare is hoping to fund an additional 1,000 residents. And while it's a glimmer of hope from the map you showed and the data you've been presenting as well, 1,000 residents against the tide of folks that don't have access to healthcare in those areas might seem minimal. But that's why I posted that there. It's just it's another instance where I think the tide is somewhat turning towards the issues being addressed about access and the number of people available to provide that access. And often the argument about access is that, well, or even fraud, is that the available physicians and providers we have now, and nurse practitioners we have now, can bill fraudulent overbilling, or maybe billing that is not necessary for medical care. But as is evidenced by adding another 1,000 funded students and residents, is that there aren't enough hours in the day to fraudulently bill in terms of the amount of clinic slots available to provide that access. And then, just to leap into parity on that, coming from a facility-based hospital system, there's been talk about creating a facility charge for the telehealth that is provided by facility-based clinics or hospital-based clinics, HBCs, and where the G0463 is being paid right now during the PHE, it does seem a little bit over much in terms of, patients aren't going into a clinic room and using stuff. Certainly we are having staff providing scheduling, education, and the other kind of things that people need to do to conduct a telehealth visit. That pricing might come down a little bit lower as well. But those are just my initial thoughts, and I'll put myself on mute again.
That's absolutely fine. Thank you.
Yeah, and I would echo some of what Carol had to say there. Going back to workforce concerns that you brought up, Michelle, I think that it's worth noting that there is a lot of focus on this, both at the state and federal levels, obviously to varying degrees in the states, but the Connect for Health Act, Schatz's legislation is set to be reintroduced this week, or possibly next, but very soon. And one of the things it does in particular this year is really put a renewed focus on how we might expand workforce, particularly around looking at making sure that folks who can provide care normally, not via telehealth, who are licensed and registered with their national boards could provide the same care based on the standard of care that they would see a patient with, any standard of care they would meet initially. And so that would actually be a tremendous advantage, I think, to the workforce, utilizing those specialists who and nurses and respiratory therapists and parts of dietitians, parts of that multidisciplinary team, physical therapists who see these folks on the daily basis that they do, who are the experts in these fields, right? And so not putting extra onus on the very few providers that we're allowing to be covered to see these patients as it is. I think that's really important to take note of. I think the other thing, when you talk about brick and mortar, and people being concerned about that cost and overutilization issues around that, I think it's really important to remember that we're looking at, the overarching theme here, right, is that we want to be taking care of these patients. We want to meet them where they are. We want to make sure that we are not laying down any kind of guardrails post-PHE that will limit or put up barriers between patients and their providers, whoever they may be. And if we limit the ability by putting in a new facility fee or any of those, or not, or taking out funding because you have a brick and mortar institution or HPC, then we're really limiting the ability of the provider to see the patient in a hybrid way, in a way that they determine is the best method for treating that patient long-term and based on what that patient needs. So, most models aren't all telehealth or all in person. Shouldn't be. We should be allowing those practitioners and physicians to determine based on the population and their needs and patients specifically, how often they need to or could be seen via telehealth versus how often they should be seen in person. And anything that places onus on them to maintain a system of providing care completely virtually is really counterintuitive, I think, and counterproductive for that matter. So I'll stop there and then I'll chime in later.
That was great. Both you and Carol add so much to the discussion, and Carol, you're so great about putting in texts and chats and links in there, important articles that folks have written that are important for our attendees to to read. And I think you made an important point on the last on the end of your discussion there, Brooke, because I think one thing that doesn't exist in telehealth as it relates to fraud and abuse, one thing that doesn't exist in telehealth right now is any kind of real best practice definitions. So where we see in other practice that we have, some standards to manage that people can speak to or can lean on, we really don't have those in telehealth. So I think we're running and judging for the fraud and abuse before we actually have the base in place. So I think for all of us who've been in telehealth for some time, we need to do that. We need to push for the standards, the best practices to be codified so that we all can benefit from that, and we can start to really pinpoint where real true abuse is. Okay, and I think we have a question. Just a moment, let me ask this question. So Michael is asking a question. I'm not a payer, but if I was, I would want to have a different arrangement. I'm not interested in parity unless you can show me that I won't get billed for a televisit if a patient comes in person for the same or related reason because something was missed. Although providers do miss things even in person, knowing that a provider organization in this case has some skin in the game would encourage them to use telehealth appropriately and to build in processes and workflows that integrate this into their continuum of care, documentation, and billing. there any thoughts on that? So I'll share my thoughts first, and then I'll ask Carol and Brooke to weigh in on this. But I understand if a payer coming, your comment here is if a payer would want to have a different arrangement to ensure that someone doesn't come in for an unrelated reason, that they missed something. But that already exists today in the same type of format that we have with a readmission. So when someone comes into the hospital, obviously, and then they're discharged, that come right back in, there is some penalty associated with that. And I think that, you know, is reasonable for us to discuss and debate. But just cutting right at the top and saying the service that was provided should be at a lesser cost is burdensome in my mind and unnecessary. If we do have a related issue that comes up with a patient, then you know, we should look at what is the other side of that. Do we have a reduced rate when they come in person within a certain amount of time for the same issue? I think that's something for us to debate and discuss. Carol and
Yeah.
Brooke, what do you think?
Yeah, I agree. And just to tack on to that, I think honestly, it's good to look at this as an opportunity. I agree with Michael, but I think, you know, in 2019, you know, HHS was announcing that it was going to explore, you know, use of advanced analytics, AI. We are really pushing the use of all these new technologies, excuse me, and you know, to detect and prevent and prosecute fraud and overutilization is one of the ways we can, you know, really look at utilizing those services and ensuring that we utilize the services, much like kind of harkening back to what you said, Michelle. We learn to do much earlier in financial services or banking or travel services, other industries. So I think that one of the tacks we might want to take moving forward when we talk about all of these concerns, regardless of how accurate we think they are in terms of reflecting what's going on around overutilization and fraud in telehealth, is that, you know, we might want to use data that's sort of already inherent to telehealth technologies to improve the program integrity around telehealth. So, you know, utilizing platforms, incentivizing the use of platforms like EHRs that already have documentation in place, like with location, participants, you know, all the things that we might need to put in there, and workflows that can ensure that we are not overutilizing or seeing patients ineffectively, is probably a really good synergy that we should be exploring in terms of policy.
Agree, Carol.
So I think CMS tried to address this by the virtual check-in, where they would check in with the patient, you know, a provider checks in with a patient, and if the patient's going to come in for an actual visit, that virtual check-in is not reimbursed, but is actually bundled with the actual clinic visit or the actual telehealth visit that results in an E&M visit. There could be other barriers around that too. Like, for instance, eConsult has the same type of parameters around it as well, where if you're going to see a patient within 14 days, then you are not providing an eConsult, you're assuming care. So there might be an argument to build in similar, I don't know, guardrails around telehealth visits. I do think, however, that I haven't read the recent studies. I know there's been some news in the last couple of days about how telehealth visits do result in clinic visits, like a 11% increase, or, you know, whatever those news articles were. But I would tend to think that's because of the third-party vendor providers perhaps not addressing or not being able to address a question. You know, they provide a very important service of, you know, being able to take care of very superficial for the moment and from my experience, superficial ailments,
Right.
pink eye, all that kind of stuff that might not be able to be covered without a trip to an urgent care center or to an emergency room for an ultrasound. So I would tend to think and encourage more telehealth so that people are actually seeking care that might be mitigated initially without having to go to that. Maybe in-person visits would have been doubled. I don't know. But I mean, there are stopgaps in place already around the e-consult and virtual check-ins. So, yeah.
I think this is a really good point. Could that have actually been would we have had more in-person visits? You don't know there's always an assumption that we're going to have a lot of telehealth visit, but we actually could have a lot of in-person visits. So those are great comments by both Carol and Brooke. So I'm conscious that we have probably only a couple minutes left with them. So I want to quickly get to a couple of other topics and maybe get some final thoughts before they have to jump off. We've talked about the market growth. It's absolutely insane where it's going and the level of investment. So that is pushing the industry, but it's also causing this concern of fraud that we've talked about in their comments. So we need to be conscious of that. And as an industry, we need to pay attention to that. The market size is predicted to be an outrageous amount, but we do potentially have the issue of creating a digital divide while we're trying to solve this problem. So we want to push towards telehealth and get our parity for telehealth, but then we may actually be pushing people away because we're using so much technology, and that's not necessarily available in all areas, socioeconomic areas, as well as rural areas. So these are balances that we need to manage, but it doesn't mean that we should abandon the idea for parity. So I want to talk a little bit about the types of clinicians that are using telehealth during pre and post COVID. So you can see pre-COVID, we really had, only a few services that were utilizing telehealth as a, as a service. And you can see psychiatry and psychology. So most of the behavioral health were really utilizing it pretty low, excuse me. They were the only ones that were using it at any type of level. And then as post-COVID, you can see we've just gone on the complete opposite side. So we've got, virtually everyone using more telehealth with the exception of chiropractors, which I think I understand completely, right? So we see services like behavioral health and other types of specialty services being utilized in telehealth, and it makes complete sense. So we know that COVID has certainly pushed everything forward, but do we now see a leveling off between those two types of specialties? And even further to that, we see a correlation, the change in weekly total outpatient visits with pre-COVID to the percent of weekly total visits that were in 2020. So the number that we see at exponential, again, still more behavioral health services. So certainly when we look at behavioral health, there is an overwhelming argument that should be at least parity, if not more, because it seems like patients are actually gravitating towards behavioral health services via telemedicine because they're getting something from that they don't necessarily get face-to-face. Perhaps they're more comfortable in their own home environment. Perhaps they are receiving different types of attention from the clinicians. They're just, and the clinicians are seeing more from the patients. We don't know, but there seems to be this real push in the behavioral health space. So I would argue that the parity doesn't need to be potentially just parity, but maybe even more when we're in a telehealth space. So I'm going to open it up for last thoughts from Carol and Brooke, but I think Carol just may have dropped off. I may have missed her, but final thoughts from either of you?
Yeah, I just need to drop off, but thanks so much for having me. And this is an important issue, and I'm glad Blue Cirrus and others are addressing this. And we all need to check on that Ways and Means Committee follow up from yesterday. That's my final thought.
Good point.
Yes,
Wait, yeah.
great.
All right, take care, everybody. Thank you.
You too. Bye, Carol. Yeah, and I'll have to jump off too, but I guess my final thought here is that we need to try to remember that sometimes that, parity is really a separate issue from, I mean, I know that it's tied, but we need to be mindful of what we're trying to really accomplish here. Telehealth is just another modality of providing care. It's a way of providing more complete and sound and quality care to patients. The research is very important around this because it is somewhat new. It's not the newest thing in the world, honestly, and we all know that, but we've been beating this drum for decades. But the research is very important. We now have a treasure trove of data thanks to the wonderful pandemic we've been living through for the past year. And I think it's really important that we focus on making sure that we are utilizing that data and harnessing it to produce basically what Michelle was discussing, which are some best practices and some guidelines around this. CMS has been pushed to put out new guidelines. They have yet to do so, or any new FAQs, and we really need to hold their feet to the fire on that. But I think that we need to remember that, kind of getting back to the who we're serving and the lessons we're learning from COVID, also I think around equity and the concerns that the digital divide has opened that up. I'm not sure that it's opened it up as much as it's revealed that we have always had big lapses in equity and care because it's a systemic issue. I think that it's really great that telehealth and the pandemic have opened that conversation back up. I think it's important to remember that while it may be perceived as creating issues, those issues probably, they're not new issues, but they can also help address them. And, it's here to stay. This is the era we live in now. It's the fourth, we bandy this about all the time, this term, the fourth, industrial revolution.
Yeah.
But, we don't have a choice but to make this better. And, it's not that horse has left the barn. So, we need to stop discussing telehealth as though it's some newfangled creation that we're stepping in the middle of. It holds a lot of potential, and it's the way we're going to have to move ourselves more towards a value-based system that is equitable and not biased, which are very different things as well. But that's another horse to flog later. So anyway, I will leave you with that thought.
Thank you, Brooke.
But thank you so much for inviting me, and thanks to everyone on this call who does such great work every day. Much appreciated.
Thank you, Brooke. Thank you,
you.
Carol. So as we look forward to other correlations of change, total weekly outpatient visits pre-COVID and post-COVID, you can really see again that push to behavioral health services as well. But we see others that are increasing primary care, many more visits there as well, and some other specialties. So we need to look at this, and then you can see the usage as well, where telehealth parity laws were enacted, and then where states where it was not enacted. And this is only through 2013, so not as fresh a data as some of these other areas. But what we do see is just an increase in the usage of telehealth, not necessarily an increase because you have a parity law, which has always been the concern. And so we know that, with these parity laws, we can see the data proves out, and we certainly have a treasure trove, as Brooke mentioned, with COVID, that we can take a look at it and see, but we're just not seeing the data bearing that out. There was fear around that, but the data is not demonstrating that. And we know we have a ton of vendors and companies that are all part of the digital health ecosystem, and we need to be careful that we don't end up in a type of siloed environment with telehealth or any type of digital health solution. So all of these vendors together, each of them may be doing great work individually, and obviously providers that are providing telehealth services as well, healthcare through telehealth. But what we need to make sure is that we see the market compression happening so that it improves the overall services for the healthcare providers. So these, I think, are factors that are affecting the digital health industry, and I think we need to bring these partners into the fold to discuss why parity of payment needs to be part of the discussion, part of the ecosystem that they are part of as well. In addition, I took a look at some of the data that we see from claims tracking over the course of a year in 2021. And when we look at 2021, this is just the last couple of months here in January and February of 2021. So we're really looking at a whole lot of telehealth. These are all telehealth visits, but we're looking at, you know, a maximum essentially of telehealth visits. We didn't see a dropping off in January and February. So we see again psychotherapy, behavioral health visits that are just absolutely on the top of the list. And then in January, we also saw just physician telephone services as well. So again, to me, this makes even more of a reason for some services as well as behavioral health in particular to even be potentially paid at least parity, if not more, because their expertise is not diminished based on doing that over a technology, certainly. And we see the volume of claims, very slight change, maybe 1% over that month time. However, and of course down here at the bottom showing you the actual services that were being provided. Interesting, COVID, obviously in January, lots of people were calling about other respiratory diseases and COVID tests, whether they should take a COVID test. But what we see from February of 2020, so a year ago, we saw services that were more primary care associated, physician patient services that were 10 minutes long. We see established outpatient visits, things like that. We don't see behavioral health visits really until, you know, you get to almost beyond these high high claims. So we see mental health as the top 5 diagnoses here, but we are just doing standard telephone visits of 5 to 10 minutes for discussion. So these are typical 5 to 10 minutes, but the diagnoses still remain mental health in that way. And then of course, acute respiratory disease based on the pandemic that we're in today. So comparatively, we see a big percentage change from the volumes of claims from 2019 to 2020. And then of course, compared to what we saw in 2021, going back, we can see that 7% and 6% essentially in 2021. So we have a huge, obviously we always know that anecdotally based on our experience that we have a huge influx of utilizing telehealth, but the way that it's being utilized is kind of interesting when you start to slice and dice as it relates to which services should receive parity or where should parity be in place, and which I'm certainly advocating for that. Also in the bottom right, you can see urban and rural. We're seeing telehealth being utilized in the urban areas even more than in the rural areas. So we know that that is probably large part due to the technology challenges that are happening in the rural areas, as well as some of the concerns that we have in the rural areas over the way that some of these waivers have been put in place. So we need to address policy so that we waylay concerns and we can see the increase in usage so that we can continue to manage chronic disease as well as some other behavioral health services, whether they're in chronic disease management, med management, et cetera. We know that CMS is moving towards improving quality and reducing cost. And we know that value-based payments are moving in that direction, but we're not there yet. There's a ton of people still doing fee-for-service. So we need to continue to move in that direction. And when we get to value-based payments, telehealth needs to be part of that. It isn't part of the bundle of, oh, you can do, we need to make sure that we have a service fee that's included in those bundles that includes that amount for telehealth. So it can't just be, oh, we're doing this service and oh, it's going to be the same and you're also going to do telehealth on top of that. We need to watch out for this, and that's the reason to do parity now, so that as we move even further towards value-based medicine, we can ensure that we include the telehealth services that are moving more and more. And we're not putting the genie back into the bottle, as many people have talked about before. And previous HHS, a CMS secretary said, you know, in-person care is the gold standard, and we know that we're not going to go back. And this is why we need to look at this from a telehealth perspective. We need to incorporate that as part of the service, create these best practices, these guidelines that our industry is aching for. And that way we're able to see a standardization of those services across, and people can feel a little bit more comfortable, not only about utilizing telehealth as a service, but also paying for it and ensuring that we don't have widespread fraud, because that's their concern right now. We don't really know how this is supposed to be utilized, and it seems like there's widespread fraud. But well, sometimes clinicians are just trying to make it work, and they don't really know how they're supposed to handle this. So sometimes you're just making just mistakes because we have you know, issues that are, you know, we're just learning things. So sometimes it's not even just overt fraud, for example. So we need to have the standards so that everyone is operating in the same way that we don't have today. So parity is required for telehealth. We need that because population is outpacing supply for our clinicians. Our clinician shortages are throughout the country. We saw the underserved population map, and we know that that underserved population is getting, that divide is getting worse and worse. And the usage doesn't skyrocket with parity. We saw that in the graph, that it was essentially on the same track. It just improved because people recognize it's a good way to address healthcare. We know that outcomes are improved. That's proven. I didn't display that today, but we know that when we touch the patient more, when we meet with the patient more, we remind them of the things that they need to do, particularly on chronic disease management, behavioral health, et cetera, that their outcomes are improved. That way costs are reduced as well. When we have better outcomes, we have better long-term care of chronic disease management. We know overall health is, the cost of care is reduced dramatically. And telehealth needs to be part of that continuum of care. That's work that we need to do in the industry, where we need to work forward on how we create those guidelines and standards. But we need those value-based payment models that are moving forward to include telehealth, not only as an option inside the payment, but also consider that as part of the payment model. And then fee-for-service telehealth rates finally should be paid at the same rate. Lots and lots of reasons why. There's more that I didn't even talk about, but this is just scratching the surface and hopefully giving all of you an opportunity to take a look at your areas, and that you can read more about this and get involved from an advocacy perspective. You heard Carol mention that the Ways and Means documents that came out yesterday that we all need to comment on and respond to. So it's important that we be involved in the legislative process as it relates to telehealth. This is a brand new, fresh industry, and they're asking for a lot of comments, and people are giving comments, and they're not necessarily always positive for the industry. So it's important that all of us be involved. Of course, we always want to thank our healthcare heroes, all of you on the call, and folks that may be listening even after we finish this webinar today. Of course, Carol and Brooke as well. Really, really appreciate all the work that you all are doing on the front lines, and thank you every day for your work. If you have any questions or you would like to contact me, please do anytime. It's my email address and phone number, but also please follow us on Instagram, LinkedIn, Twitter, and Facebook. And we should have Instagram. And also on our website, we have tons and tons of information in the Knowledge Tsunami, including all of our previous webinars and our radio shows, which do great interviews with industry leaders, kind of in a podcast fashion. So I will open up to questions. I know we're just over time.
Hey, Michelle, thank you so much. I would like to note, due to a technical issue, I didn't get to tell you guys earlier, but Carol is Carol Yarborough, and she's a healthcare compliance and reimbursement specialist at UC Health. And then Brooke is Brooke McSwain, who is a policy research analyst for health IT, public health infrastructure, and heart and brain research for the American Heart Association. So those are the guests we had on today.
Thank you so much for that. I appreciate that. I know we had questions during the presentation, so we may have asked all the questions, or people are still absorbing it. But if you do have any other questions, or you just want to talk about this topic, I am always up for it. I've heard a presentation by a great speaker that was against parity, and I thought I'm motivated to talk about parity, and I want more people to talk about it as well. So I think if we talk about how we get parity and why is it important, it's so important to our industry, and I want to be part of that discussion. So happy to talk anytime. Thank you everybody for being here, and we will have a webinar next month. One of our consultants, Tiffany Johnson, will be doing she's a medical student from the University of Las Vegas, and she will be doing a presentation on public health and the use of telehealth with public health and the importance of public health. So we felt like that was a timely topic given everything that we've all been learning. So that should be an interesting one. Thank you so much for being here. We look forward to having you next month.